everybody. We're here with Dr. Jason Scoppa. He is the TMJ specialist, and he's someone that we refer patients to, because he has a lot of knowledge, and he's going to share some of his knowledge with us today. Welcome.
Hey, thank you for having me on the podcast.
You're welcome. So let's talk a little bit about what you do and how it's different from another chiropractor, for example.
Sure. I use a technique called SOT, and I use another one called AK. So these are both just chiropractic techniques that take into account a little more than just joint dynamics. So obviously the chiropractic adjustment is a good tool in your toolbox, but sometimes I found that it wasn't enough, especially nowadays. It's funny though, you talk to a lot of older chiropractors, that are 70, 80 years old, and they say it used to be different. I don't know if the food, the emotions, like something, but they said, they used to just be able to adjust people, and they didn't have any of these other layers of things, and people would get better and great, but nowadays I think our life's more complicated. There's more things we have to EMFs and stresses that we didn't have, 60, 70 years ago. So I found I needed more tools in my toolbox. So I try to kind of go after things a little bit more than just looking at the joints. We want to look at other things as well. So that's kind of what, just to get better patient care. That's what made me go down those roads.
That's amazing. And what fascinates me about you is that you have the best tool, which is the patient's own body, to guide you and how you're doing things and what else is needed to be done. So can you explain a little bit about that and how you use the body of the patient to know what's next?
Yeah, you're absolutely right. Yeah. I mean, it's about function. I mean, like, perfect symmetry is important, but I mean, I don't think you can diagnose a lot of the things that are happening in somebody structurally and functionally off of like an X-ray. It's just, we're a lot more complicated than that. And yeah, so it helps me to have indicators. So the patient's body is essentially telling me every time they come in, what's the priority? What are we going to work on that day? And then whether or not we achieved our goal or not. So it's not just me guessing or the patient oh, does that feel better? Yeah, I think it feels a little better. I mean, that's important, right? But we want to make sure, I mean, that gives me confidence too. If a patient's like, oh, this is still hurting me a little bit, but if the indicators are gone, then I could have a lot more confidence in saying to that patient, pain is an indicator, but the other indicators are fading. Like, I'm pretty confident this will go away. If it doesn't, let me know. But I could say that with a little more confidence than just, you don't want to overtreat a patient or do something just for the sake of doing something. So yeah, it helps me a lot as a practitioner to let the body kind of guide treatment. And the body, is the most powerful healer, so it wants to get better. It wants to heal itself. So just removing as many of those interferences as possible so the body can just do its thing. Yeah, I think the body's a powerful, it's a powerful system for sure. So we just want to let it, much more powerful than anything I have. So just kind of removing those interferences to let it do its thing.
Yes. And can you please explain people a little bit about how exactly you do that and how you get the answers from the body?
Yeah, sure. I mean, there's so many good techniques and so many ways into the body in that way. Like I said, I use SOT and AK. So AK is applied kinesiology. So it's looking at three things. They call it the triad of health. So it's the structure, the mental, emotional, and the chemical. And so we use muscle testing to get into the system in AK. There's another technique I use called MRT. So MRT was developed by someone named Louisa Williams, and she created a system. I think it's a little less subjective than the muscle testing, so I use that sometimes as well to get an idea of where to go and what to do on any given visit. And then with SOT specifically, we're looking at indicators in the body that are. We put the body into essentially in SOT. We put it into three categories: category 1, category 2, category 3. And then within that category, that's kind of the umbrella. And then within that category, there's different things we can check during the visit. And we may or may not do all the procedures. It just depends on if the indicator is not there to do this procedure, then we move on to the next indicator to do this one. But it's under kind of the umbrella of the larger category system. So it's helpful for me to kind of know where the patient is in a larger frame, but also in the individual visit. And some patients we get into some nutritional things, and some patients we don't. It just kind of depends, who they're seeing. We have so many good naturopaths and other doctors around here. So if that side's being handled, then you only have so much time during a visit. So I'd really try to focus my attention on other things because I know those are being covered. So I might not get into those things at all. So it just depends. Yeah.
So you mentioned something about the psycho-emotional, and that's something that I'm passionate about, and how it can affect how the patient is responding to treatment, or actually how it can be the reason of the problem that the patient is having. So can
Mm-hmm.
you talk a little bit about that, please?
Sure. I said that triad of health with the physical, the chemical, the mental, emotional. The mental, emotional is the one that I do the least of, and then I'm the least qualified and trained. So I'll just tell you what I found anecdotally. But I do think it's probably the most important one. I agree with you. And I think it's the most stigmatized one. And I think it's the most poorly addressed of all of those things. And it's the hardest one to address, right? Because physically you can get in, someone can work on you or give you some exercises and it's more of a collaboration. And then the chemical side, there's things you can take, a supplement, a prescription, or whatever, and you can have it addressed that way dietarily. And when you resolve it, you resolve it. But the mental emotional trauma, no one can fix it for you, right? They can help guide you, but it's never going to go away. You just learn to live with it and cope with it and deal with it in an ever evolving process. So it's a lot more complicated, I think, than the other. I have it on my intake form. I say, do you have any, physical, emotional, sexual abuse? And so if they mark that, I tell them, you don't go into detail. You don't need to even talk about it. You don't want to talk about it with me. I'll probably make you worse, but it's just important for me to be aware that that's there, because they're a lot more likely to be stuck in something you're aware of. I mean, the fight or flight response. So our fight or flight, our nervous system only has two modes. It's sympathetic, parasympathetic, and that's it. It's one or the other. And we're in a constant kind of back and forth. And it's good. You need both. You want both. Most of the time, you want to be in parasympathetic, because that's where you're healing, you're digesting food, you're assimilating food, your tissues repairing themselves. I mean, that's where it's good sleep. That's where you want to be most of the time. But a lot of people nowadays, because of that triad I mentioned, one of those three, they get stuck in this sympathetic dominant state. So if you're stuck in a sympathetic dominant state in the mental emotional field, you could have nutritional deficiencies, you could have physical issues, maybe unrelated to that. But because you're stuck in that sympathetic fight or flight response, you're not going to get the same result as the next person that is not experiencing those mental emotional traumas. Those people are going to get a lot faster, a lot better results, because they're in parasympathetic, where you can actually utilize these tools and your body can assimilate them faster. So it's like, for example, sometimes somebody that's in like a sympathetic dominant state that's had a lot of terrible things happen to them, sometimes they can't. I usually have a 30-minute follow-up treatment session. Sometimes we can only get 10 minutes into that, and they go into something called a total yin response, which is just every muscle goes weak. They just completely just go, and that's the body's just like, I'm done. Like, I can't take any more input right now. They can't handle very much. So these are people that get just pushed over the edge very easily. Could be an argument with a friend. It could be they eat a little too much of something that maybe the next person could eat a lot of, like something, noxious, like, some kind of sugar, ice cream, or whatever. Maybe that person can handle it, but the person with the sympathetic dominance, it'll just push them over a cliff. So, in that way, it's important for me to know, because I said, I just talked to them about what I'm just discussing with you, kind of tapering expectations for results because of that. And then I also ask them how they are, like, where are you in that process? And some people, I'm doing really well. I feel like I'm in a good place with that, or I'm working with somebody and we're really doing good. Like I feel like I'm stable. And if that's the case, it's great. And I maybe won't mention that again. But if they say, yeah, I really struggle, or I'm not where I want to be, or, I've tried XYZ, therapies and they haven't done it for me, then I try to kind of talk with them about, well, are you open to trying something else? And then suggesting some things, if I know of anything else that they haven't done, then kind of talk them through that and explain to them how it's tying in potentially to what's going on with whatever they're coming to see me about, and just trying to get them to somebody that can help them potentially, so that that issue could be resolved. But also it'll be easier. I'm selfish, right? It'll make my job a lot easier too, right, if they get that dealt with. So it's a win-win for everybody. And in terms of even people that haven't had awful things happen to them in childhood or whatever else, just pain itself, um, can cause a sympathetic dominant state. So that alone can lead to, there's four different types of receptors in our body. So the fourth one, it's nociceptors. So nociceptors are pain receptors, and when those fire, it also drives sympathetic dominance up. And so we want to inhibit those class 4 nociceptors, and you can do that through physical medicine, which is cool. So stimulating type 1, 2, 3 mechanoreceptors inhibits type 4 mechanoreceptors, and you do that through physical medicine. So it's pretty neat. So, but the physical pains are usually the last thing to come, and it's the first thing to go away. So just because we got rid of the pain doesn't mean like everything's fixed. So that's why, to your question before, you can't go off of pain as the pure indicator for whether to treat somebody or not to treat somebody. Um, in terms of afferent signals coming into our body, how many, you might already know this, how many per second afferent signals of all kinds are we getting? It could be the truck down the street, it could be pain, it could be the temperature. Like how many, what do you think we're in terms of our
Thousands.
huh?
Thousands. How many?
3 trillion per second.
3 trillion.
Afferent signals to our sensory cortex in our brain per second. So that's what our body's having to deal with. How many of those are we conscious of? How many of those are, and that includes pain. How many of those are you aware of?
Maybe
50.
50
50 out
out
of
of the 3 trillion.
3 trillion. Yeah, 50. So, pain is a fraction of the afferent sig. So we cannot go off of pain by itself. That is a fool's errand. We have to look at other things in the body to help us, and we'll never get them all. I mean, but a lot of people think that's the basis of things like autism, things like that. It's actually they're aware of more than 50. They're aware of, and it's like they're just overload. That's why they need a low sensory environment, because they're just. I mean, can you imagine if even if it was like 100 that you were aware of, it would drive you insane. You know, so it's our body purposely shuts out a lot of things and filters what we are aware of or not aware of. But like I said, pain is one of those 50, and so. Um, it's I said that in and of itself, we want to get rid of it because it can drive that sympathetic dominance. But that's just one thing out of many that we could potentially work on. So yeah.
Exactly. And I love what you said, that pain is the last one to come, and it's just kind of the last resource of the body to give you a message that something is going on. Same
Mm-hmm.
thing when we are having TMJ pain, the temporomandibular joint discomfort is after. So there's many reasons for that pain, but for example, if we're talking about the psycho-emotional, if there is that sympathetic nervous system is activated,
Mm-hmm.
the patient might be clenching and grinding their teeth, and then the consequence down the road will be pain on their joint. So
Mm-hmm.
let's talk a little bit about how there's different reasons for us to experience TMJ pain, and
Mm-hmm.
then clenching grinding is one of them. But then
Mm-hmm.
there's other reasons, and you see a lot of those cases. And
Mm-hmm.
just let's talk a little bit about, so people understand why they could experience some pain on their joint.
Sure. Well, yeah, it's like you said, one, the clenching and grinding is a good, and that clenching and grinding can be from, people do that because of cranial strain, a lot of cranial faults, that kind of thing. And the body's kind of trying to self-correct that on their own. It could be from airway, right? There's research behind that. But it could, their bite could be meticulous. Their jaw could be perfect, and it could just be from the mental emotional trauma, like you said. So that's, the grinding and clenching is, if you're trying to work on somebody with jaw pain and you can't to get them to stop grinding and clenching, you're going to fail for sure. So, that has to stop for sure. But there's quite a few things that can cause jaw pain. There's a couple of cool studies out of Japan where they took people with even leg lengths, no jaw pain, and fairly even occlusion on both sides. When they bite down, they hit pretty evenly on both sides, and they put a heel lift on one side of in their shoe, and they had them walk around for a few months. And on the side of the short leg, they started biting harder on that side, and they started getting jaw pain on that side. So even as far away as leg length can have a significant impact on your bite and the condyle position of your jaw joint. So I'd say there's a lot of ascending I'm just going to call them ascending factors, but that's, could be leg length. SI joint is a huge, huge deal. The SI joint specifically. So there's things called proprioceptors in our body, which are like little GPS units in all of our joints. So it gives us our spatial awareness, and it contributes to our balance. You can walk into a dark room or close your eyes and move your wrist or move your shoulder. You don't have to look at it to know what it's doing. It's because of those proprioceptors. All of our joints have them, but the joints with the most amount of them are the SI joints and the jaw joint. So if there's a significant issue with SI joint proprioception, that's definitely going to have an impact on the jaw joint. The jaw joint's a huge compensator for a lot of ascending. The cervical spine is another big one. Even the teeth, the dentate ligament in the teeth, they have a lot of proprioceptors in the dentate ligament. So if there's a lot of major bite problems, that might show up in the jaw joint. And so, the jaw joint might be having symptoms, but the main cause of the jaw pain is the bite or the SI joint or the leg length or whatever. So if a lot of those things go on long enough, sometimes the jaw will degenerate and they will actually have now two problems, right? They'll have that bite problem still, but then they'll also now have a degenerated, jaw joint or, one that's partially off the disc or completely off the disc or whatever the case may be. So the jaw joint compensates a lot for those ascending factors. Another big one would be tongue position. So that's a really big one. A lot of people with low tongue posture, either because of a lack of tone or because of a tethered tissue, they can't get their tongue up. And so when the tongue's down, it moves with the mandible. So the tongue and the jaw start moving together, but that's a dysfunctional pattern. That the tongue should be up and then the jaw is loose and it can move where it wants to go. But when the tongue's down, it's very rigid and it'll lock the jaw in certain positions and it pulls the jaw in certain positions. So sometimes it's the tongue is involved with jaw issues pretty frequently, I would say. And then kind of along those lines, maxillary underdevelopment is a huge. I'd say that's probably the number one cause of jaw dysfunction is the maxillary underdevelopment. So meaning
the maxilla, that upper part, is not either wide enough or maybe it might be shorter. So for people to understand, it might be retruded. So
it's almost always both. So when you look at the way that the cranium grows, the cranium when you're growing, and I know you know this, but I'll speak to the larger listening. I don't know who else is going to listen to this, but so when you're a baby, the foods you eat, both the density of the food and the content of the food, as well as the tongue position, will impact the way the maxilla grows. And genetics is a part of this too. And this is something that, chiropractors, craniopaths, we don't know anything about cranial growth and development. Dentists, orthodontists, you guys don't know anything about cranial growth and development. The ones that really know are the cranial paleontologists. Like they are the ones That's where I had to go to learn this stuff, because I would be hearing things from the chiropractic group, the SOT, craniopaths, like brilliant people, but they would just be saying things and all kinds of contradictory, and you go to a dental conference, right? And you go to one course or another course, and there's this expander and that expander, and they're just talking, they're just saying things, but there's no, it's like there has to be some consensus on this, and there is, but it's the cranial paleontologists that have developed uh, this understanding. So I'd love for more of them to get involved with they're just disgusted with what goes on in the orthodontic community, the dental community, because I said it's just like the Wild West, right? The people are just pushing and pulling and all kinds of forces and all these things. So it's, but that maxilla, I said that like the chewing, it helps develop the muscles that guides the bone growth in the maxilla. It's the lack of sugar in the diet, which leads to, so if there's more sugar, it leads to more mouth breathing at night. And then that leads to a narrowed, underdeveloped maxilla, the mouth breathing.
Sugar can cause underdeveloped
Oh,
growth.
yeah. Yeah, that was like the Weston A. Price studies, where he did the studies on the Aboriginal people. I mean, it's really dramatic. Like when they introduced that Australian diet versus the traditional diet, just not just the effect on the teeth, right? The teeth, the health of the teeth themselves is just, I don't know anything about that. That's your specialty, right? But that was a disaster. But also the shape of like I said, they couldn't nasal breathe anymore within one, not just like the next generation, that generation, and it led to a really small and narrow maxilla. And then the tongue position, as when you're a baby, the cranium's really soft, squishy. So that tongue, especially when you're sleep, you release the most amount of growth hormone during sleep. So if the baby's sleeping with their lips together, that tongue's probably going to be up. And when the tongue's up on the palate like that, it's the pressure of the tongue that guides the growth of that maxilla, and it makes room for the dental arch and the maxillary sinuses. But if the tongue's down and the mouth's open, then it grows narrow and retruded. But the cranium doesn't grow. There's no primary growth center that's lateral in the cranium. So all these lateral expanders, there's a different. They make a very clear distinction between growing bone, remodeling bone, distorting bone, or pushing teeth. So which one is it, right? And so the lateral expanders, the ones that are done, some of them push the teeth, and you can tilt. If you go too fast, if you don't do it right. But even if you do it like correct, and the teeth go, it's just distorting the bone. It's not actually remodeling or growing the bone. And so what that means is you can distort bone any way you want, but if you take out the stimulus of that distortion, it goes back to the way it was. So with a pretty high degree of certainty that over time, that's going to relapse if cranial growth and development.
They're doing now with surgery, they're breaking the suture in the maxilla.
The intermaxillary suture.
Correct. So they're expanding that way. Maybe there's relapse when you do it that way.
There is. Yeah, there's no way it would relapse. However, it's the A to P that's the primary growth.
Yes, the anterior, posterior.
Yeah, and the maxilla, it actually, this is a big misconception too. Like everyone thinks the maxilla grows anterior. Like it doesn't grow anterior. The growth actually comes in the back. It actually grows posterior, and it displaces anterior. And so as it comes forward, then it expands lateral with the forward displacement. But when the forward happens, it leaves room for your jaw to come down and forward. So a lot of those cases of the purely lateral, the MARPE expansion, those people are they're gonna nasal breathe better. So if their main complaint is nasal breathing, you will definitely be able to breathe better through your nose when you crack open that maxillary suture. What are the repercussions of that, like medium to long term, of cracking open a suture like that? I don't know. They don't know. Nobody knows. I've asked. They have no idea. So kind of TBD on that one. It's pretty invasive, but they do a good job with it, and I've had patients get it, and they have a good result with it. But if you're having a jaw issue, and especially if you have a degenerated jaw joint, most of the time that jaw needs to be, it doesn't need to go back. It needs to come down and forward, to some degree. And if they're A to P deficient, they have nowhere to go. So a lot of these people, their nasal, and then that's also impacting their pharyngeal airway if they're A to P deficient. So a lot of these people,
Sleep apnea patients that have
yeah,
sleep
yeah,
apnea.
like obstructive sleep apnea, yeah. So a lot of these people, they get that the MARPE done, but it's only really addressing one out of 4, 5, 10 problems, right? And so a lot of times they'll look at the before and after of those pictures, and I'm not like bashing this technique. I think all of them have holes, right? So it's just, but the MARPE, it's like a popular one right now, and it kind of drives me nuts. It's like everybody needs to go get a MARPE, and it's just like, hold on, like, if nasal breathing is like your only real concern, then it's great. But it's because, like you said, it won't relapse. But to me, it's there's a lot of holes in that system. It said they're not addressing, and a lot of them add the SFOT with the MARPE, which is like the surgical facilitated orthodontic treatment. So then they're just kind of randomly moving your teeth into like some aesthetic bite, but you're still working around potentially a severely underdeveloped A to P maxilla. So you're still kind of dancing around the elephant in the room without addressing the elephant in the room, So
And that's why it's important, and we recommend people to see a dentist that knows more about that relationship between the mouth and the body. An integrative dentist that is maybe using not only one appliance, because not everybody is the same. So we need multiple appliances that are going to achieve different things. Because yes, as you said, there's not only just one problem like nose breathing. There's usually multiple problems. Malocclusion, the
almost always, right? Yeah, it's almost impossible to just have one of those things, right?
exactly, yes. And we're seeing a lot of kids nowadays, they're having a lot of problems, like their nose breathing, then their mouth is open, more decay. It's just a complicated, like one thing after the other one. It's like a snowball effect. If their tongue posture is not in the right position, then we're going to create bigger issues. But one of the interesting things that I discovered last year is that they did a section of the fascia of the tongue. Did you see that? And it can go all the way to the toe
Yeah. Oh, yeah. 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 Yeah.
connection. So
It's
that
cool.
probably also correlates in how what's happening in our mouth is going to be affecting the rest of the body and vice versa.
Hmm.
As you were saying, so if there is an imbalance on the hips or the shoulders or the neck, then we might have some problems in the mouth or in the TMJ, the joint. So
Yeah.
what have you noticed? And you were talking about the cranial, just this imbalance, right? That can cause some of the jaw problems. Can
Hmm.
you talk a little bit more about that, and how is that connected with the rest of the body or the posture, or what
Hmm.
is it that people need to do to know that the probably the posture is not helping their jaw, other than of course they have malocclusions and the
Hmm.
tongue is not in the right position, or maybe they're they need some expansion, or there's just some orthodontic treatment that is needed. But besides that, maybe the posture can be causing some of the problems.
Sure. Can I speak to something you just said first? Is that okay?
Yes, yes.
Well, you said, yeah. I mean, I think it's great that there's this movement in dentistry towards, more holistic type dentistry. Is that you guys are still like the 1% though, right? I mean, like but I think it's great that this podcast exists, and other, there's like a put like airways the hot thing right now, but I'm hoping that leads to more knowledge of like the jaw joint and like you said, postural, kind of opening the door to these larger things rather than just kind of these narrow, I mean, just looking at airway through a narrow tube is the same at just looking at aesthetic bite through a narrow tube, right? I mean, it's all just I'm hoping that like in dentistry, because you guys have so many powerful tools. I mean, it's just amazing. I mean, you guys, I would kill to have the tools you guys have to fix some of these things. Because you guys can honestly like really fix the root cause of a lot of this stuff, which is amazing. But most of you don't even know it, right? So it's like it's wild that it's just an interesting. I could point out a lot of these things, but I don't have a lot of the tools to. I can't literally change this. I'd have to walk around with my finger in somebody's mouth all day. Like I just can't. I don't have time for that, but yeah, it's not feasible. And then, to your point about all the different appliances and it's like, I wish, sometimes I think, because it's so hard for you guys just to learn one of those. Like, it's so, I said, I'm a part of a orthodontic study club, and I try to go to a lot of dental orthodontic conferences, and most of it's like way over I have no idea what's, they're talking about power chains and all this kind of stuff. I don't know what this stuff is, right? But the point is, what I got out of those is how complicated it is. Like the work, like the physics of moving a tooth, it's really amazing. I mean, like there's so much to keep in mind, and you do one thing and it just sends this ripple effect through the rest of the bite. And so just to really get good at any one of those appliances, I think really takes a lot of effort and study. It's not like, I think a lot I mean, myself included, before I went to these, I just didn't appreciate uh, how nuanced and how complicated it is. So I said, I mean, even if you just got really good at one of these appliances and just refer, if it wasn't a good fit for your box, just refer to I don't, this isn't really a good fit for the tool I have, but like Dr. Joe down the street is like awesome at that. And then there's like a nice referral network between, so you don't have to know everything, right? Because
It's impossible.
it's impossible. And it's like, I mean, and those courses cost a fortune, and the time and I mean, gosh, like just to learn one of those, like I said, is really incredible. So, but anyway, so I just wanted to comment on that, but yeah.
And one of the things that kind of came to mind is how when clenching and grinding happens, a lot of the dentists, they just recommend a nigar, and they just fabricate a nigar.
Yeah.
And sometimes that nigar can cause more problems to the patient, especially if, for example, they have a narrow airway and they're having either a lower or upper nigar. Those nigars are pretty bulky, and that can make things worse. And the other thing that I've learned from you, and thank you very much, is that we should be doing lower nigars instead of upper nigars. Can we talk a little bit about that, please?
Yeah. I absolutely agree. I mean, night guards, I think I'd say most of the time they're actually, I don't know, airway I can't assess in my office, right? You need something like an echopharyngometry or something to assess the airway and see. But you're right. I mean, it has that potential for sure. Even appliances that are made really, really accurately, like a neuromuscular appliance, which is like pretty spot on musculoskeletally. I've seen it where those are perfect, but then you do an echo on that person and their airway hates it. And vice versa. You put somebody in like a mandibular advancement, like an airway plug and play appliance, and you do an echopharyngometry reading and their airway is so happy, but then you hook them up to the neuromuscular equipment, and their musculoskeletal system is on fire. Like it hates, they have tons of jaw pain, and it's like a disaster. So it has to be like a marriage between, because they said not everybody has both problems, but if they do, then to me it's you have to take into account both. Because you wouldn't want to save somebody's teeth, cut off their airway, right? And then, or to just to save somebody's teeth with a night guard, create headaches and neck pain and tinnitus and all kinds of other issues, right? So, but the upper, so there's a suture on the pull out my friend here. So there's a suture on the maxilla, but there's not one on the mandible. So there's the reason I like the lower appliances in general, not just night guards, it's just any appliance, opposed to an upper, is unless you're going for tooth alignment, like an Invisalign kind of thing, you kind of have to have an upper, because but for if it's for a jaw joint, if it's for protecting teeth from hitting each other, like a night guard situation, any other situation, I think the lowers are better, just because there's less potential for it to cause any kind of cranial tension or any dural distortion, because we have a suture in our maxilla, but we don't have one in our mandible. So if you have something that's restricting that suture, it's going to create tension through the head down into the neck because of the dura, versus here there is none. So people tend to tolerate. I've tested people with uppers, and some of them test fine, but I'd say 80% or more, maybe 85%, don't do well with uppers. And then getting the height calibrated is really important. And then I think sometimes they're just too rigid. I think one of those three, and maybe somebody can tolerate all three. Maybe somebody can tolerate two of those being off, but not the third one. Everyone's different, but those are generally one or all of those three things are the reasons why people don't do well with the upper appliances, and they do a little bit better usually with the lowers.
Mhm.
Yeah.
Great, great. So, what are things that you would recommend people in general to have to prevent pain, discomfort, and what are the recommendations you provide your patients in general for having a balanced posture and body and free of pain?
Yeah, so I mean, there's like basic things, right? Like movement, and it's this stimulating mechanoreceptors inhibits nociceptors, like we talked about earlier. And so, if your joints are moving well and they're healthy, then you're probably not going to have pain in that joint. I mean, like what is the definition of osteoarthritis? It's a loss of joint space. So it's a dysfunctional joint causes pain. So I think moving your joints as much as possible is good. There are some people that have like hypermobility issues in certain joints where you wouldn't want to, like you said, the body's telling them to. A lot of times, if you have like the jaw joint's a good example of this, the shoulder, the hip. If there's a degenerated joint or a joint that's dysfunctional, sometimes the body will tighten all the muscles around that joint to create stability at that joint. So you wouldn't, the body's trying to tell you like, hey, something's wrong. Stop moving me. I don't want to do any more damage. But then, we're going in there and stretching it or, doing all this stuff with the jaw joint and X. That's why I really don't like a lot of the stuff I see online for jaw problems. It's like people grabbing their jaw and like whipping it everywhere and stretching it and all these things. And it's just like, sometimes that's safe to do. Sometimes that is, you're just going to cause more tension in that jaw or in the shoulder or whatever it might be. So sometimes you have to address the joint issue to then stabilize. You want to stabilize the joint, not mobilize the joint. And once you stabilize it, the muscles don't feel like they have to clamp down like that, and they'll just let go by themselves. Like they don't have a mind of their own. They're not just doing that to be difficult, right? The brain's telling that to happen. So if you take away the stimulus, then the brain won't need to do that anymore. And then getting the proper amount of minerals is really important. Eliminating as many inflammatory foods and that's a big topic, but yeah, just whatever that means for you, I guess. Cutting down on your general amount of inflammation. I think EMFs is a big deal. I've seen that affect patients in different ways. So like at night, I'll put my phone on airplane mode. I unplug the Wi-Fi router at night. I get all the devices out of my daughter's room if there's any in there. Just try to it's so easy to do. And it's like, even if it makes a 2% difference, like why? It's low hanging fruit, right? Like
Exactly.
why not do that? It's really important. And yeah, in terms of symmetry in the body, I think getting the bite and the tongue and all that stuff. I mean, going back to the question you asked a while ago, and I went off topic and talked about something else, but I think getting as much symmetry in the body and then setting the bite to that, getting the cranium level, getting everything unwound, then setting the bite to level and functional. Then every time somebody bites down, it's pulling them back into a healthy place. Versus, if you come in and you're torqued and your maxilla is twisted and and then you could have a maxilla that's tilted this way and you're hitting harder on this side. And, the orthodontist might shave your teeth down on that side to get your occlusion even, but now they've locked you into that cranial strain. So they can come see me every day and I could lift that up on that. If I could find it, I lift it up. But by the time they eat lunch, it's like everything's back to where it was before. So I think I just think the role you guys play is just a vital, like I said, in terms of kids and making airway space and working with the tongue and getting all this level, the stomatognathic system and the way that impacts the rest of the body. The cranium itself, there's a dura, that covering of the brain and spinal cord. So that dura has a loose attachment at every nerve root level going all the way down the spine, but the main attachment sites, the strongest attachment sites, are at the bottom and the top. At the bottom, it's down at the sacrum, and at the top, it's into the cranial sutures. So we try to get as much torque out of that dura as we can. So in the pelvis, it's great. We do a great job with that. SOT, we do a great, we don't want to mobilize that joint very often. We mostly want to stabilize it much more often than mobilize it. But in the other end, I mean, I can untorque that cranium, but if they have a lot going on in their bite, their airway, their jaw joint, I mean, they're going to have problems. That cranial distortion is going to come back. They're probably their head's going to come forward if they have a pharyngeal airway problem. I could try to work on their curve every day for the rest of their life, but most of the time, this forward head posture is not text neck or anything else. They used to read by candlelight. You know what I mean? So it's like this whole text neck thing is ridiculous. Like people used to have dark candles reading books at night. Like you don't think they were like this too? But they didn't have these problems because their maxilla was good, right? Their airway was open. Their diet was a lot better. So it's not the phones. It's the airway, and a chiropractor cannot fix that. We cannot. There's no way a PT can't fix it. Again, you can go see that person every day. You have to get the airway fixed. But I said to me, it's a lot of the cases I see, as you know. I mean, I send them a lot of people to get co-managed just because I leave it up to them. I'm just like, hey, if you want to come, this is a situation. I tell them whatever I find in the bite or the jaw or whatever is going on, and then usually they come in with jaw pain or neck pain or headaches or something like this. So I kind of point out what I find. Usually there's something going on here. And so, I pointed out to them, but you never know what the pain generator is going to be, right? So, like I said, there's a lot of different things that impact these areas. So I work on the things that are easy for me to work on. Sometimes their pain goes away in a few visits and they're good to go. And then, as long as I don't think they have an airway issue, right, then I tell, there might be something going on with the jaw or the bite, and I'll point it out to them. I'll say, hey, your pain's gone. It's great. There's other stuff going on. So if it does come back, you might have to address these things. Let me know. And they go on their way. And then, some people to get to where they want to be goal wise, then they have to address these things. They have to stabilize the jaw joint. They have to fix the bite. And the airway is it's a huge one it's in and of itself. It's a big deal. It's just the working as a team, I think, is really important, and then catching all these things early, because a lot of people, I mean, it's amazing. I'm sure you see this all the time too, but I mean, there's a girl who's working at my front desk who's been into your office before, but she was like, oh, can you look at me? I was like, yeah, sure. And so she came in and she had like a grade 4 tongue tie, and she's, like 30 something years old. And so no one ever said a word to her about it. I mean, this isn't like this was just like, oh my gosh. Like, and her main symptoms were like headaches and neck pain. And like, I'm just like, what are we doing here? This is crazy. You guys need to go see, I just send them over to you guys. I mean, they need to have this addressed because, and yeah, I mean, sure enough, she had that addressed, and it doesn't always happen like this, but like almost all her symptoms. I mean, it was like,
it's amazing. Yes.
Yeah. I mean, we could have treated her every day. And
so once more, the tongue is kind of the main actor of a lot of problems that we are dealing with.
I think it's an actor. I think sometimes with the myofunctional therapy stuff, I think sometimes that's gotten kind of overblown to some. It's super important, but I think it's kind of made overly complicated sometimes. Mm-hmm. And I think it's part of the whole thing. I mean, I'm sure you've seen this as well. I mean, I've had tons of patients where they have such high expectations for the myofunctional therapy and the tongue tie release, and they get it done, and they're like, I'm exactly like I was before. I mean, it's part of, not even in all cases. In some cases, I think it's more important than others, but it's part of the whole package of things. And I think it's the most important thing is to get the right diagnosis. Like, do you have one of these problems? Do you have two? Do you have 10 different problems? Like, what's going on? And then kind of address them as you need to, like starting with the one that's the easiest to address. And then whatever their goals are, if you can address it through as non-invasive a way as possible, conservative way as possible, then great. And then you can get kind of more and more complicated from there, I guess, right?
Yes. No, I love it. And it is important to have that multidisciplinary approach, right? Having all the different aspects looked at.
Yeah, I think that's vital. And in a lot of these cases, I mean, I think it'd be impossible for one person to do all these things. Like it really would. I mean, and then it's just tough to, because it's like, who's in your area? I mean, I could tell you, I could sit here and say, oh, everyone needs to go see an SOT doc. There's not an SOT craniopath in every city. Like, there's not that many. So it's like, well, what do you do if you don't have, like, I don't know. And then with protocols, it's still kind of the Wild West with the protocol. Like, what do you address first and when, and who to see when, and collaborating care that way. So it's a growing, we're always growing, learning, evolving, and fine tuning. And I said, it's definitely not, it's not, none of this is finished by any means. I mean, it's kind of just starting, I think. It's in its infancy, the collaborative aspect, and that even the appliances, like, it's just crazy right now. But I think my hope is that as more of that, uh, the cranial paleontology work comes out, that it's going to start kind of bringing a lot of things into perspective. So a lot of these appliances will either be phased out or modified, or because you guys are super creative. Dentists are like, they're like chiropractors. I mean, we come up with all kinds of crazy things. Some of them work amazing. Some of them don't work very well. And there's everything in between. But like, that's kind of one of our strengths, I think, is the creative aspect, versus the orthodontists. I don't find them to be very creative at all or very open-minded at all, but they're technically really, really, really skilled at what they do. So it's like we all kind of have our part to play. I think it's just how to coordinate with each other, put egos aside, and then just really look at not what I think and what I feel necessarily. That's important, but like also like what is like a factual information about like what needs to happen and what's the best way to do this. And I think there's multiple right answers, and I think there's a lot of wrong answers.
That is true.
Yeah.
Well, everybody should go see you before they go see their dentist.
No, well, it's a team thing. I mean, that's it's like but it's just I said it just depends. It's tough. It just depends on who's in an individual's area. I was recently in China visiting my in-laws, and I had the opportunity to talk at this big. It's a dental and orthodontic hospital in this city in China, and it was amazing. Like, they were so excited and just so, like, I thought it was just going to be like a lunch with somebody at this hospital, but it ended up being like I sat in front of their board, like the board of directors at this hospital, like the head of orthodontics and the head of pediatric dentistry, and I didn't have anything prepared because I thought we were just getting lunch. So I'm like, yeah, I could talk about this stuff all day. It's exciting, and we were just started and like they were very open to what they knew and what they didn't know, and they were very open to, you know, just like, hey, like, we want to get better. And I was like, hey, great, like, let's just talk. And it was just, and the way they interacted with each other, there was no ego, there was no, because they all work in the same building, and they all, none of them are competing for patients or any of this stuff. It was just amazing. It was just like, what's the best way to do this? Like, what are we missing? And like, how do we all work together? And I was like, gosh, like, I don't know if this could ever happen here. Like, honestly, I was like, this is like, I was telling them, like, I don't know. A lot of the things they were using were kind of a little bit archaic in terms of but they knew what they did well, and they knew what, because they would get clear patient, everything was the records were kept very well. Like, was this a successful case? Were there problems with this case? So they knew where they had problems, and they knew where there were deficiencies. Like jaw pain, TMJ was a disaster for them, like complete disaster. They were in kind of the infancies of learning about airway, but they didn't really know a lot about it. Just like they were just but I said they were really, a lot of times you don't know what you don't know, right? But if you know what you don't know, then you can learn, right? But if you think you know everything, you can't learn. If you don't know what you don't know, you can't learn. But if you know what you don't know, then you can learn. So,
and help more people.
yeah, I mean, and I said I was just so impressed with. I just kept telling them, like, wow, you guys are like, I mean, it's just really, I don't know. It was like next level. I was just, this is incredible. Yeah, they don't have like a lot of individual dental, like private offices. A lot of them are in these like hospital like settings. And so you go in and then everything's there. And I mean, there's pros and cons, but I think in terms of collaboration, it makes things a lot easier, right? I mean, well, even for our patients, right? You guys are in Edmonds and I'm in Bellevue. Like, people don't love that, you know? It's like, but it'd be great if like all in one building with the myofunctional therapy and the, you know, a dental surgeon and like everyone's together. I mean, it's just like, how cool would that be? You know,
Oh my gosh, that's a dream.
I
Yeah.
mean, amazing, amazing. Yeah.
Well, thank you so much. And I'm going to add all the information and where they can find you, your website and phone number.
Okay.
But thank you so much. Thank you for sharing your knowledge.
No, thanks for having me. Yeah, it's always fun to talk shop. Thank you so much.
Thank you. Thank you so much.